Welcome to the deep dive. Today we're tackling a really important topic using a stack of your detailed revision notes. Autosomal dominant polycystic kidney disease, often just called ADPKD or even APKD.
That's right. And you've given us some pretty comprehensive material here. It looks like it covers, well, pretty much everything you need. So our mission today is really to unpack all that detail, pull out the absolute high-yield stuff, and hopefully make this complex picture a bit clearer, easier for you to, absorb and remember.
Yeah, because ADPKD is actually quite common. It's an inherited condition, and getting a grip on the key features is, well, it's vital, whether you're revising or just want to understand it better. So let's dive right in.
Okay. So at its absolute core, the definition is ADPKD is a genetic disorder. That's the starting point.
And the main thing it causes, the big issue.
It causes multiple cysts to form in the kidneys. These are like fluid-filled sacs that just shouldn't be there.
Right, and they grow.
They do. They start small, but they tend to grow over time. And as they get bigger, they take up space, making the kidneys enlarge, sometimes quite significantly.
And that's the problem, isn't it? The growth.
Exactly. That growth progressively pushes aside and replaces the healthy kidney tissue, which means, inevitably, kidney function starts to decline.
And even though the genetic issue is there from birth, you typically see it diagnosed later, in adulthood.
Yes, that's usually when it manifests clinically. It often reveals itself over time. And importantly, while the kidneys are ground zero, so to speak, the notes are clear. It can affect other organs, too.
Okay. And the notes highlight two main types. This feels like a key distinction to grasp.
Absolutely. High yield for sure. There's type 1, which is linked to a mutation in the PKD1 gene that's on chromosome 16.
And that's the common one.
Yep, accounts for about 85% of cases.
And the key thing about type 1, compared to type 2,
the notes really emphasize that type 1 tends to be, well, more severe in its progression. People with PKD1 mutations often reach end-stage kidney disease, needing dialysis or transplant earlier in life.
Okay, so PKD1, think earlier, maybe more severe. What about type 2 then?
Type 2 is linked to the PKD2 gene, which is on chromosome 4. Less common, making up the other 15% or so of cases.
And the pattern there is later onset.
Generally, yes. Kidney failure, if it happens, usually occurs later in life compared to type 1. So that simple rule, PKD1 equals earlier, PKD2 equals later. That's a good takeaway from these notes.
Got it. And the underlying mechanism for both is those mutations in PKD1 or PKD2. What do they actually do?
They essentially mess up the normal development and function of the renal tubules, those tiny tubes inside the kidney.
Ah, okay. And that disruption is what kicks off the cyst formation.
That's the trigger, yes, for the cysts and also for the effects we sometimes see in other organs.
Right. So moving on from the definition, let's look at the why, the etiology, the risk factors.
As we've said, it's primarily those genetic mutations, PKD1 or PKD2.
And just hitting that type 1 point again, the notes say PKD1 mutations aren't just more common, they're also linked to worse outcomes.
Consistently, yes, more severe disease. But the absolutely critical point, the one you really need to remember about the cause, is the inheritance pattern.
Which is?
Autosomal dominant. And that has huge implications for families.
Okay, break that down. What does autosomal dominant mean for, say, a parent with ADPKD?
It means for every child they conceive, there's a 50% chance, a 1 in 2 chance, that the child will inherit that mutated gene and develop the condition. It's literally a coin flip each time.
And it's important not to confuse this with ARPKD, autosomal recessive.
Exactly. The notes are very specific on this. ARPKD is different. Different gene PKHD1. Different inheritance pattern recessive, meaning you need 2 copies of the faulty gene, usually 1 from each parent carrier. Totally separate condition.
Okay. So given that dominant inheritance, the biggest risk factor for ADPKD is pretty obvious then?
Family history. Yeah, absolutely. It runs in families.
But there's a twist.
Well, a couple of points the notes make. While most cases are inherited, about 5% are actually caused by new mutations. Spontaneous ones called de novo. No family history there.
Right, which might explain why. Or was it? About 25% of people diagnosed don't actually know of a family history.
Precisely. Maybe the affected parent wasn't diagnosed or had very mild symptoms, or maybe it is one of those de novo cases. So you can't completely rule it out just because someone says no family history.
Good point. Okay, let's get into the pathophysiology. How does this actually work inside the kidneys?
So those gene mutations, PKD1 or PKD2, they fundamentally disrupt how the kidney tubules develop and grow normally.
Right, messing up the plumbing.
You could say that. And this disruption, it triggers the formation of those cysts.
But once they start, they just keep going.
Yeah, the notes describe them as gradually expanding, relentlessly getting bigger.
And pushing out the good stuff.
Exactly. They progressively replace the vital, healthy kidney tissue around them.
And that's the process leading to the decline in function, the crowding out, the damage.
That's the direct consequence, yes. Although, interestingly, the notes mention that the exact mechanisms driving the cyst growth itself, how they actually expand, are still being actively researched. We don't know everything yet.
Still mysteries to solve. Okay, so if someone turns up with kidney cysts on a scan, it's not automatically ADPKD. What else could it be? The differentials.
Yeah, critical step. The notes list several things to keep in mind, like acquired cystic kidney disease that can happen later, especially in people who already have chronic kidney failure for other reasons.
Okay, well.
There's medullary cystic disease, nephronophthosis. These are also genetic, but often present a bit differently.
And simple cysts.
Oh, definitely. Simple acquired kidney cysts are super common, usually totally harmless, and they increase with age. You absolutely have to distinguish those.
And you mentioned ARPKD again?
Yes, autosomal recessive PKD is on the list too, just to reinforce. It's different from ADPKD.
Any others?
Medullary sponge kidney is mentioned, and tuberous sclerosis. That's another genetic condition that can cause kidney cysts, along with problems in other organs like the brain and skin.
So, a fair few possibilities. Seeing cysts is just the start of the investigation. Okay, epidemiology. The numbers. How common is this?
Well, in the UK context mentioned in the notes, it's about 1 in 1,000 people. That makes it the most common inherited kidney disease.
And globally.
The figures vary a bit more, maybe 1 in 500 up to 1 in 4,000, depending on the study and population.
But still, that's a lot of people worldwide.
Oh yeah, millions. Somewhere between 4 and 7 million people affected globally.
And its impact on kidney services is significant.
Hugely. The notes say it accounts for something like 7 to 15% of patients needing renal replacement therapy dialysis or transplant, and about 10% of people currently on dialysis have ADPKD as the cause.
Wow. And new cases leading to end-stage disease.
In Europe, it's estimated at 6 to 8 new cases per million people each year.
Any particular group more affected? Gender? Race?
The notes suggest no significant bias there. It seems to affect men and women and different racial groups fairly equally.
And just hammering home the transmission. Mostly autosomal dominant, 50% risk per child. We covered the 5% new mutations and the 25% without known history at diagnosis.
Yes, and the notes also briefly touch on the scenario where both parents have ADPKD, which is rare.
What happens then?
Well, the child has a 25% chance of being unaffected, 50% chance of inheriting one copy like the parents, heterozygous, and a 25% chance of inheriting two copies, homozygous. The notes state that being homozygous is often fatal before birth, very severe.
Gosh, really underlines the genetic aspect.
Oh.
Okay, let's shift to what someone might actually experience. The clinical features, symptoms and signs.
Starting with the kidneys themselves, pain is a really common one. Abdominal, flank, or loin pain.
And why does that happen? What causes the pain?
Could be a few things. A cyst might suddenly bleed into itself, or they might be passing kidney stones, which are more common, or they could have a kidney infection, pyelonephritis.
Okay. And blood in the urine, hematuria.
Another key feature. The notes specifically flag gross hematuria, so visible blood, especially if it happens after some kind of trauma or bump to the abdomen. That's described as a classic presentation.
Infections seem like a big issue, too.
Very common. UTIs, urinary tract infections, are frequent, and they can easily track upwards to infect the kidney itself, causing pyelonephritis.
And stones.
Yes, kidney stones are definitely more likely. Interestingly, the notes specify that uric acid stones seem to be more common in ADPKD than the typical calcium oxalate ones.
Huh. And underlying all this is the slow decline.
That progressive decline in kidney function,
Yeah.
leading towards chronic kidney disease, CKD.
Anything else kidney-related?
The notes mention problems with concentrating urine properly, meaning the kidneys might struggle to hold on to water and salt effectively.
Okay. Now, what about blood pressure? Hypertension?
This is crucial. It's incredibly common in ADPKD, and often it's one of the very first signs. Sometimes it appears years before kidney function noticeably drops.
So it can show up quite early.
Yes, even in young adults, maybe their 20s or 30s. Sometimes the only sign might be, say, morning headaches. Definitely something to look out for.
Right. Now, beyond the kidneys, those extrarenal manifestations, what else gets affected?
The most common target outside the kidneys is the liver. Hepatic cysts.
Liver cysts, are they like the kidney ones? Problematic?
Well, they're common, and they tend to increase with age. But the key difference, according to the notes, is that they're usually asymptomatic, no symptoms, and critically, they generally do not cause liver failure. That's an important distinction.
Okay, that's reassuring. What else?
The brain, this is a serious one. There's an increased risk of cerebral berry aneurysms.
Brain aneurysms and the danger there is.
Rupture. A ruptured aneurysm causes a subarachnoid hemorrhage, which is a type of stroke. Very serious. The notes also mention these aneurysms can sometimes press on nerves, causing things like cranial nerve palsies or even seizures.
Wow. Okay, what about the heart?
The heart and blood vessels can be involved too. The notes list things like mitral valve prolapse, other issues with mitral or tricuspid valves, the aortic root widening, and even aortic dissection, a tear in the main artery. Cardiomyopathy, weak heart muscle is also mentioned.
So quite a range of potential cardiac issues. Any other organs?
Cysts can pop up in the pancreas, though rarely causing pancreatitis, and also the spleen. Less common, though.
And physical signs someone might notice?
Things like abdominal hernias are more common.
Uh-huh.
Also, a separation of the abdominal muscles called rectus abdominis diastasis.
Anything else listed?
Male infertility is mentioned, possibly linked to cysts in the seminal vesicles or affecting sperm motility.
Interesting.
And one more brain-related point. Cysts in the arachnoid membrane, which covers the brain, are linked to a higher risk of subdural hematomas, which is bleeding under that covering.
And aneurysms aren't just in the brain?
No, the notes say they can occur elsewhere in the vascular system too.
Okay. The notes then seem to recap some kidney complications under clinical features.
Yeah, it reinforces some key points. That classic gross hematuria after trauma, renal colic, which is severe pain from clots passing down the urinary tract, kidney failure, often developing between the 40s and 60s, being able to actually feel the enlarged kidneys on examination, usually both sides.
And the UTIs and pyelonephritis again, plus those uric acid stones.
Exactly. Then there's the question of screening people before they have symptoms, if they have a family history.
Right, pros and cons.
Benefits could be earlier detection and management of complications, maybe informing family planning decisions.
But the downsides?
Potential risks mentioned include discrimination, like for insurance or employment, and the psychological impact of knowing you carry the gene for a condition that might cause problems down the line.
That's a really tricky balance. How do you weigh that up?
It's clearly not straightforward, requires really careful discussion and counseling for each individual, considering their circumstances and values.
Definitely. And finally, under clinical features, what might you find on physical examination?
Well, as mentioned, you might actually feel the enlarged kidneys or an abdominal mass.
A heart murmur could be a clue.
Yes, if there are associated valve problems or aortic root dilation.
And those abdominal signs.
You might see a hernia or that rectus diastasis and potentially an enlarged liver, hepatomegaly, because of the liver cysts, even if they're not causing direct symptoms.
Okay, so we know what it is, why it happens, what it looks like. How do we actually diagnose it and monitor it? Let's talk investigations.
Imaging is absolutely fundamental. Renal ultrasound is usually the first test.
And the notes give specific criteria for diagnosis with ultrasound.
Yes, and importantly, these criteria depend on the person's age and whether they have a known family history of ADPKD.
Okay, can you run through those?
Sure. If there is a positive family history, for someone under 30, finding 2 or more cysts in one or both kidneys is enough. Between 30 and 59, you need at least 2 cysts in each kidney. And if they're over 60, it's 4 or more cysts in each kidney.
That age variation makes sense. Accounts for simple cysts increasing normally.
Exactly. CT scans of the abdomen and pelvis are also used, often with similar criteria. MRI can be helpful if ultrasound isn't clear. The notes mention a criterion of more than 10 cysts per kidney for MRI.
And lab tests.
Standard stuff mainly. Your analysis may be culture if you suspect a UTI. Blood tests like electrolytes, urea, creatinine to check kidney function.
Anything else?
Fasting lipids are mentioned as a possible prognostic marker, maybe giving a hint about disease course.
And other tests depending on the picture.
Yeah, an ECG if there's a murmur or heart concerns, maybe a plain X-ray like a KUB to look specifically for kidney stones or calcification.
What if there's no known family history? How do you diagnose it then?
The notes say you need either clear bilateral kidney enlargement with cysts or multiple cysts in both kidneys plus liver cysts, and importantly, no signs pointing to a different cystic kidney disease.
And genetic testing, is that commonly done?
It's an option, yeah. Can confirm the PKD1 or PKD2 mutation, particularly helpful if the diagnosis is uncertain or maybe in younger people considering family planning. The notes mention it can potentially be used for prenatal or pre-implantation testing, but there are complexities.
What kind of genetic tests?
Older methods like linkage analysis require affected family members. Newer sequence analysis looks directly for mutations, but it's complicated because there are so many possible mutations in those genes.
Right, not always straightforward. Okay, let's move on to management. Once diagnosed, what's the plan?
The overall aims are clear. Control the symptoms, try to slow down the kidney damage, and prevent or manage those complications we've discussed.
How do you do that? General strategies.
Blood pressure control is absolutely paramount. Almost always needs medication.
Lifestyle stuff.
Yep, low-sodium diet is usually recommended. Avoiding things known to harm kidneys, like certain painkillers long-term.
Treating infections promptly.
Essential, especially UTIs, and the notes mention women are more prone.
And keeping an eye on things.
Regular monitoring of kidney function is key. Blood tests, sometimes imaging.
And if things progress.
Eventually, if it reaches end stage, then it's renal replacement therapy dialysis or a kidney transplant.
Okay. Any specifics on medical management? Blood pressure target.
Yes, the notes aim for 130 over 80 millimeter Hg, quite tight control.
Preferred drugs.
ACE inhibitors or ARBs are usually the first choice.
Managing hematuria, blood in the urine.
Usually conservative, pain relief, rest, plenty of fluids.
And kidney pain.
Treat the underlying cause if you can find one infection, stone, bleed, and be really careful about avoiding long-term use of potentially kidney-damaging painkillers like NSAIDs.
Right. Dialysis when needed. Any specific advice for women?
Yes, the notes caution against using estrogen-containing meds because of potential effects on particularly liver cyst growth, and pregnancies need careful oversight.
Okay, now this is a big one. Is there anything that can actually change the course of the disease, slow it down?
Yes, this is important. The notes specifically mention a medication called tolvaptan.
Tolvaptan, what type of drug is that?
It's a vasopressin receptor antagonist.
And who is it for?
According to these notes, it's for adults who have chronic kidney disease stages 1 to 3 and show clear signs that their disease is progressing rapidly.
And what does it do?
Critically, it can slow down the rate at which the kidney is enlarged due to cyst growth, and it can slow the rate of decline in kidney function. The notes even mention the Tempo 3.4 trial, which showed it works.
That's significant. A disease-modifying therapy. How do you monitor progression generally?
Regular blood tests for kidney function, regular ultrasounds to track kidney size. Catching high blood pressure early is vital, sometimes using 24-hour ambulatory monitoring.
And the notes said, ultrasound might be better than blood tests for tracking.
Yeah, mention as potentially more sensitive than just serum creatinine for seeing how quickly things are changing.
What about managing the liver cysts? Polycystic liver disease.
If they're asymptomatic, usually nothing needs doing. If they cause significant symptoms due to size, there might be interventions considered to shrink them or reduce liver volume, but again, the key point, they don't usually cause liver failure.
And those brain aneurysms, how are they managed?
MRA magnetic resonance angiography can be used to screen for them, but the notes stress it's only in specific cases. Routine screening for everyone with ADPKD is not recommended.
And if you find one?
Deciding whether to treat an asymptomatic aneurysm is complex, based on size, location, patient factors, and that caution about estrogens comes up again regarding liver cysts.
Genetic counseling is also part of the package.
Absolutely essential. To provide information about the disease, complications, prognosis, and the genetic risks for family members helps people make informed decisions.
And finally, general patient support and advice.
Give clear information, written materials help. Advise against contact sports, risk of trauma causing cyst bleeding.
Standard healthy living stuff, too.
Yep. No smoking, maintain healthy weight, regular exercise. All good advice. And the key is tailoring management to the individual. It's not one size fits all.
Right. So wrapping up, what's the long-term picture? Prognosis.
Big point from the notes. It's highly variable. Some people do okay, maintain reasonable kidney function for a long time. Others progress fairly rapidly to end-stage renal disease.
But monitoring and management make a difference.
Definitely. They're essential and can impact the outcome.
The notes gave some timelines based on genetic type.
Yeah, for PKD1, the more common type, about half of people reach end-stage kidney disease by around age 60.
And PKD2.
It's typically later. About 50% reach end-stage by around age 75. Really highlights that difference in progression speed.
Are there factors that predict faster progression?
Yes. The notes list several. Having the PKD1 genotype, multiple pregnancies, being of Afro-Caribbean ethnicity, male sex, diagnosis at a younger age, having particularly large kidneys early on, and uncontrolled hypertension is a big one.
Okay. And finally, a quick summary of the main potential problems, the complications, many we've touched on.
Yeah, it's a recap, really. Chronic kidney disease progressing to end-stage renal disease is the big one.
Kidney infections, pyelonephritis, and kidney stones.
Cysts rupturing or getting infected in the kidneys or liver.
Cardiovascular issues, especially that high blood pressure. Major complication.
And those cysts in other organs potentially becoming symptomatic over time.
But the positive note is that good management can help.
Yes, regular follow-up and proactive management can definitely reduce the risk and severity of many of these complications.
So that was quite a journey through these ADPKD notes. What are the main takeaways?
Well, we've defined it: genetic, cysts in kidneys, other organs too, autosomal dominant inheritance, that 50% risk. The PKD1 versus PKD2 difference is key for prognosis. We've covered how cysts cause damage, the differentials, how common it is.
Yeah, the wide range of features, pain, hematuria, the crucial link with hypertension, those serious brain aneurysms. Then how we investigate using imaging mainly and lab tests.
And management focusing on blood pressure, lifestyle, treating complications, and importantly, the potential role of tolvaptan in slowing things down for some people. Plus the variable prognosis and the list of potential complications.
Hopefully breaking it down like this straight from your notes makes that high-yield info clearer and easier to remember.
For memory hooks, maybe think kidneys, cysts, pain, stones, failure. Cardio, HTN, aneurysms, valves. Liver, cysts, but usually okay function-wise. Remember, autosomal dominant, 50% risk, and PKD1 earlier, tougher, PKD2 later.
Good summary. And a final thought, maybe picking up on that screening point.
Yeah, it's interesting, isn't it? The notes really touch on the complexity of genetic knowledge, balancing the potential medical benefits of early screening against real risks like discrimination and the psychological weight. It shows how genetics impacts lives way beyond just the biology.
Definitely something to mull over. Well, hopefully this deep dive provides a solid foundation for you. Keep building on it.
And if you're looking for more resources, particularly for exam revision like the MSRA, you can check out pasthemMSRA.com.
And also freemsra.com for, well, free resources.
Absolutely. Worth a look.
Thank you for joining us for this deep dive into ADPKD. We really hope it was helpful for your revision.